Welcome, future colleagues. I'm thrilled to have you here today. We're diving into a true masterclass on a clinical sign you are going to encounter almost every single day on the wards: jaundice. Now, we aren't just going to sit here and memorize symptoms today. We are going to build a rock-solid, ground-up understanding of exactly how jaundice works, from the fundamental biochemical physiology all the way to advanced clinical pathology. Let's jump right in.
Here is our quick roadmap for today. We'll start with the journey of normal bilirubin, then officially define jaundice. After that, we'll compare hemolytic versus obstructive pathology, look specifically at jaundice in neonates, and finally wrap up with clinical diagnostics.
Section 1. The journey of normal bilirubin, the origin story. Our story begins with the erythrocyte. Imagine the red blood cell. After an average lifespan of about 120 days, these cells become old and too fragile to survive in the circulation. So their cell membranes rupture and they get engulfed by tissue macrophages, the reticuloendothelial system that acts as the body's cleanup crew. When these macrophages split open that hemoglobin, they release globin and heme. The iron from the heme is salvaged and shipped off, leaving behind a straight chain of 4 pyrrole nuclei. And that right there, my future doctors, is the exact birthplace of bilirubin.
So let's trace this factory line. The first substance formed from that leftover heme ring is biliverdin. But it doesn't stay that way for long. It's rapidly reduced to free bilirubin, which we also call unconjugated bilirubin. Now, this unconjugated form is highly lipid soluble, meaning it needs a transport vehicle. It hitches a ride by binding strongly to plasma albumin to travel through the blood. Within hours, it hits the liver, gets absorbed through the hepatic cell membrane, and drops its albumin carrier. And here is the absolutely critical step. Once inside the hepatocyte, it meets the vital glucuronal transferase enzyme system. About 80% of it gets conjugated with glucuronic acid to form bilirubin glucuronide. Boom! It's now completely water-soluble and can be safely secreted into the bile canaliculi and eventually right into the intestine.
Now, I always love asking my students on rounds, what exactly gives stool its normal brown color? Well, here is your answer. Once that conjugated bilirubin reaches the gut, bacterial action converts it into a highly soluble substance called urobilinogen. The body is incredibly efficient, right? So it reabsorbs about 50% of this urobilinogen straight back into the blood via the enterohepatic circulation to be used again. Of the portion that stays in the blood, the kidneys filter about 5% into the urine, where exposure to air oxidizes it into urobilin. That's what gives urine its yellow hue. But the rest? It stays in the feces, gets altered and oxidized to form stercobilin. And stercobilin is exactly what makes stool brown. If you master this normal, healthy flow, the pathology we're about to discuss will make perfect sense.
Section 2. Defining jaundice, the broken state.
By formal definition, jaundice, or icterus, is that yellowish tint you see in the body tissues, specifically the skin and mucous membranes. It happens when large quantities of free or conjugated bilirubin just start accumulating in the extracellular fluids. But listen closely. Jaundice is not a disease itself. It is a systemic symptom. It's an alarm bell for an underlying metabolic, hematologic, or structural failure. It's your patient's body telling you that our beautiful physiological pathway has completely backed up.
And the absolute crucial number you need to burn into your memory is 1.5. A normal plasma concentration of bilirubin is hovering right around 0.5 milligrams per deciliter. You aren't going to visibly detect clinical jaundice in the skin or the sclerae of the eyes until plasma bilirubin exceeds 3 times that normal limit. So specifically, when it crosses that 1.5 to 2.0 milligrams per deciliter threshold. And in severely abnormal conditions, man, it can skyrocket all the way up to 40.
Section 3. Hemolytic versus obstructive jaundice, the 2 major pathways.
There are basically 2 main ways this whole system breaks down. In hemolytic jaundice, we've got a prehepatic problem. Red blood cells are being destroyed, or hemolyzed, so rapidly that a perfectly healthy liver is simply overwhelmed. It literally cannot excrete the bilirubin as fast as it's being formed. The result is a massive spike in free, unconjugated bilirubin in the plasma. On the flip side, we have obstructive jaundice. This is a posthepatic or intrahepatic issue. The rate of bilirubin formation, totally normal. But the bile ducts are blocked, maybe by a nasty gallstone or a tumor, or the hepatic cells are damaged by hepatitis. So the bilirubin enters the liver and gets conjugated normally, but it's trapped. It can't get out into the intestines. This gives you a massive spike in conjugated bilirubin in the plasma.
Look at this image here.
It brilliantly illustrates exactly why that conjugated bilirubin ends up back in the blood during an obstruction. Notice the delicate anatomical structures of the liver cells and those tiny biliary canaliculi. When there's a blockage downstream, the conjugated bilirubin backs up. The pressure rises and rises until pop. It literally ruptures those congested canaliculi. The conjugated bilirubin then regurgitates directly back into the lymph, leaving the liver, and washes right back into the systemic bloodstream. It's essentially a plumbing disaster.
Section 4. Jaundice in the neonate, a very special population. When you're examining newborns, you are frequently going to see a mild yellowness in their skin and eyes during the first week of life. As a physician, you'll spend a lot of time reassuring anxious parents that this is just physiological hyperbilirubinemia. See, immediately after birth, the neonate's liver is basically still booting up. It functions poorly for the first few days and just lacks the full activity of that glucuronal transferase enzyme we talked about. Because it can't conjugate quickly enough, plasma bilirubin rises to an average peak of about 5 milligrams per deciliter before naturally falling back down as the liver matures. It is totally, completely normal.
However, we have to deeply contrast that normal state with a severe pathological one, erythroblastosis fetalis. This happens due to an Rh factor incompatibility, usually an Rh-negative mother immunized against her Rh-positive fetus. Her antibodies cross the placenta and just mercilessly destroy the fetal red blood cells. The infant's body panics and attempts a rapid replacement, flooding the circulation with immature, nucleated blastic red blood cells, which is where the name comes from. But more importantly for us, this extreme violent hemolysis causes a dangerously massive release of bilirubin.
And if we leave that unchecked, it leads to catastrophic neurological consequences. Because neonates have an immature blood-brain barrier, those extremely high levels of free, unconjugated bilirubin, which remember is highly lipid-soluble, can cross directly into the brain tissue. If there's any asphyxia present, it damages the basal ganglia, causing a devastating and permanent condition known as kernicterus. This right here is exactly why we monitor neonatal bilirubin so aggressively on the pediatric ward, and why we use treatments like phototherapy to convert that dangerous bilirubin into easily excreted lumirubin.
Section 5. Clinical diagnostics, putting it all to the test. All right, let's walk through this ultimate diagnostic table step by step. This is where your physiological understanding actually pays off on the wards. If we run a Vandenberg blood test, hemolytic jaundice is going to show unconjugated bilirubin, while obstructive shows conjugated. Makes sense. But look closely at the urine and stool. In a total obstructive jaundice, absolutely no bilirubin is reaching the intestine. No intestine means no bacteria to convert it to urobilinogenin. Therefore, urine urobilinogenin is completely negative. And with zero urobilinogenin to eventually become stercobilin, the stool loses all its brown color and becomes this pale clay-colored stool. Meanwhile, because conjugated bilirubin is water-soluble, those massive amounts trapped in the blood get filtered out by the kidneys. If you physically shake this patient's urine cup, it's going to form an intense bright yellow foam. In hemolytic jaundice, you see the exact opposite. Heavily increased urobilinogenin, but completely absent urine bilirubin. Why? Because that unconjugated bilirubin is tightly bound to albumin, and the kidneys just cannot filter it.
I want to conclude our explainer today with a provocative diagnostic puzzle for you all. If a patient presents to you with intensely yellow urine foam, but totally negative urine urobilinogen, where exactly is the breakdown in their biliary system? Apply that biochemical mastery we just built. Yellow foam means water-soluble conjugated bilirubin is freely floating in the blood, and negative urobilinogen means absolutely nothing is reaching the gut. The answer? A total posthepatic obstruction. You're likely looking at a lodged gallstone or a tumor. Look at that. You have just successfully traced a molecule from a dying red blood cell all the way to a definitive clinical diagnosis. Keep reviewing these pathways, and I will see you in the next explainer.